Hello, everyone, and thank you for joining the Policy Lab webinar series. Policy Lab is a research center within Children's Hospital of Philadelphia's Research Institute. Our care for children and families drives our research, informing practice and policy to improve child health. This webinar series is just one of the many tools we use to translate the work under our 5 research portfolios into evidence-based policy solutions at the local, state, and federal levels. Today, we'll be focusing on the current landscape for sexually transmitted infections among teens and how we can address this growing issue with Dr. Sarah Wood, a faculty member at Policy Lab, assistant professor of pediatrics at the University of Pennsylvania's Perelman School of Medicine, and attending physician in the Craig Dulcimer Division of Adolescent Medicine at CHOP. I'm going to hand it over to Dr. Wood to get us started.
Hello, everyone, and thank you for taking your time today to join and learn a little bit about what's going on in 2020 with the state of STIs, and also a bit about what some of the policy interventions we can use and think about to change our current course. So we'll be reviewing the main topic, which is state of STIs, talking about changing course from where we are now to trying to reduce those STI rates in teens. We'll talk about what quality comprehensive care is and how we ensure it across health systems. We'll talk about improving universal screening for sexually transmitted infections in youth, scaling up evidence-based prevention in youth, and then I would definitely be remiss if we didn't acknowledge the fact that as I'm recording this webinar today, we're in the midst of the COVID-19 pandemic, and you'll hear throughout this webinar how we really want to place sexually transmitted infections within a larger social and ecological context. And so we'll talk a bit about the ways that the current COVID-19 pandemic may affect STI rates, services, and policy in the future, and we'll wrap up with a few key takeaway points. So the main messages that I want to go through today are that although we're going to be going over some pretty striking numbers about STIs, I want us to all keep calm and break the STI stigma. So what do I mean by that? Number one, although STIs are a major public health issue, most are easily treatable, and this is a real boon when we attack a public health problem. Again, thinking about where we are with COVID-19 and addressing a problem where we don't have treatment, most of the infections that we'll talk about today, treatment is easy, safe, cheap, and readily available. And so most of what we're going to talk about is getting the right treatment to the right people at the right time. Number two, we know that when we have sort of fear-based messaging or panic around sexually transmitted infections, it doesn't help patients or reduce infection incidence. So you'll hear me talk a lot today about sexually transmitted infections and not sexually transmitted diseases. Now, I'll tell you, some of my slides will say STD because that's the language that's still used by a number of different public health organizations. But when we focus about talking about infection rather than disease, that emphasis is really on our sort of first point, that most of these infections are treatable, and that when we wrap shame and stigma into our discussions about STIs and sexual health, really all we do is turn our patients away and make them feel potentially stigmatized or judged by health systems. One of the key messages we think about with youth patients is we want them to keep coming back. So we want message that's strength-based, that's positive, and is a message of resilience and a message of hope. And finally, given this easily available, easily treatable, cheap, and ready to disseminate nature of STI treatment, I really want to emphasize that as providers, advocates, educators, and policymakers, we can all work together to improve care and health outcomes for teens in this area. Now, given all that, let's talk about what the current U.S. landscape is for STIs. Unfortunately, we know that over the last 5 years, we've seen steady consecutive increases in STI rates across the United States. So those are increases in chlamydia, which is the most common reportable infectious disease in the United States, as well as increases in gonorrhea and all stages of syphilis, including congenital syphilis. here in Philadelphia, we have the third highest STI rate in the United States. And while we know that Philly's name is the city of brotherly love and sisterly affection, it is not actually because Philadelphians are having that much more sex than anybody else. The reality is that many of the things that we see driving these high STI rates are related to other major policy issues, such as funding for housing, funding for health care, and funding for access to health services through programs like transportation. So in fact, Philly having the third highest STI rate in the United States has more to do with the fact that we are one of the poorest large municipalities in the U.S. Than it does with the individual sexual behavior of our citizens. And lastly, we've seen some new trends that let us know that we're really in what we think of as a generalized STI epidemic in the U.S. So we've had a resurgence of congenital syphilis in the U.S. in the last few years. And we know that when we start seeing syphilis in newborns, that's kind of the canary in the coal mine. That lets us know that it's not only specific populations that are being infected with STIs, but that it's really across our U.S. population that we're seeing these changes in the incidence of STIs. Now, I said that we see a generalized epidemic in the U.S., but that doesn't mean that all populations are affected equally. So we know that youth, when we think about young people, we really think about 15 to 24-year-olds, are going to make up the disproportionate share of STIs in the U.S. So while that age group makes up only a little bit above the quarter of the sexually active population in the U.S., they account for more than 50% of the STI burden in the U.S. And that's important for a few reasons. One is, as a pediatrician, I'm always thinking about the developmental lens. So does an STI mean the same thing when someone's 13 as it does when they're 30? And I think likely it doesn't. What I want to emphasize is that we know that early STIs set up young people for potentially having poor health outcomes down the line. For instance, in young women, we can see that infections like gonorrhea and chlamydia can lead to pelvic inflammatory disease, thereby causing long-term effects for fertility or chronic pelvic pain or risk of ectopic pregnancy. But we also know that the behavioral change that we can affect in youth may actually be more substantial than in our older population. So even though we see these higher infections in youth potentially setting young people up for long-term health consequences, on the flip side, I want to emphasize that when people are in their adolescence, we have a really golden moment for behavioral change that can set people up for better health outcomes throughout their lifespan. So I often hear this question of why. Why are we suddenly seeing these higher rates of sexually transmitted infections in the U.S.? And as I alluded to earlier, we really have to think about this across multiple sort of planes of existence. So we think about a social ecological model or context as a system where we think about how individual, interpersonal, neighborhood, and societal factors can affect a health outcome. So for STIs in adolescents, on the individual level, we've seen increased rates of substance use in adolescents over the last decade. Certainly in Philadelphia, we're kind of at the center of the opioid epidemic as well. But even when we think about what we think of as those sort of lower risk drugs like marijuana or thinking about alcohol use, we've seen steady increases in those rates. And we know that when teens are impaired from a substance use perspective, it may be more difficult for them to make the decisions that they want to make about safer sexual activity. We've also seen that rates of condom use have decreased in teens over the last 10 years, and that we definitely see different sort of normative beliefs about condoms, meaning how acceptable they are or whether or not everybody's using them within teen populations. And that really gets us to our interpersonal strata. So we think about what are the normative social behaviors, and that has changed a lot, I would say, not just in terms of condom use, but also in the digital age. So the use of geosocial mobile applications like Tinder or Grindr to find sexual partners has really in a lot of ways lowered the barrier to having unprotected or non-condom protected sex amongst young people. But we also think about those interpersonal relationships that aren't necessarily between sexual partners. And a key one for adolescents that makes them unique from their adult population is that parent and teen relationship, where there may be issues of confidentiality, there may be issues of stigma or fear about disclosing to your parents that can also contribute to a higher risk for STIs. On the neighborhood level, as I mentioned before, we think about things like access to health care, unstable housing, and poverty as being contributors to the STI epidemic. Some of that is because you may not be able to get into a clinic if you're in a situation where you don't have health insurance or are living below the poverty line. You're not getting tested, you're not getting identified as having an STI, and thereby, for an individual teenager, the amount of time that they spend able to transmit their STI may be longer. But the other way I think about it is that when people's basic needs aren't being met, when we think about things like food, housing, and shelter, it's very hard for people to make those sort of self-care decisions or those critical decisions about things like sexual decision-making when your basic needs are not being able to be addressed. And lastly, on a societal level, we've seen how a number of different policies have led to these increased STI rates. So over the last 10 years, more than 50% of STI programs have faced substantial cuts. We also see that in our schools, the rates of sexual education and standardized sexual education have dropped significantly. We also have fewer teens going to brick or mortar schools and more children doing cyber schooling or charter schooling, which may not have the same mandates for health education as a brick and mortar public school. And then finally, even though we've seen an expansion of insurance under the ACA or the Affordable Care Act, we know that for teens, insurance barriers can be quite substantial to getting STI care. For instance, while we often make the assumption that people with private insurance rather than Medicaid may have better access to services, in reality, many teens with private insurance may be less likely to get tested for STIs because of the concern that an explanation of benefits or a bill may go to their parents and thus disclose their sexual activity status. So it's really not one single factor that's driving forward these changes in STI rates for adolescents, but really a confluence of what's happening on those individual, interpersonal, neighborhood, and societal levels. So knowing all of this, let's think about the next question, which is how do we change course? So what does research tell us? Well, research kind of gives us four major messages that you're going to hear from me today about changing our STI epidemic in the U.S. And the first is the need for comprehensive care. So we need to expand our funding and expand our capacity building to allow for quality STI services in both primary and specialty care settings. And you'll hear from me a little bit more about what that word quality means and what it can look like for teens. Our second point is that we need to improve routine universal screening for sexually transmitted infections and HIV in adolescents. As we'll talk about, particularly in the world of pediatric and adolescents, we're still well below the screening guidelines of what we should be doing for our most vulnerable teen patients. My third point is expanding treatment. So we need legislation and policy in place to be able to have STI treatment reach all teens. And that means including supporting the use of expedited partner therapy for adolescents. And we'll talk a little bit about what EPT is and how we can expand it for teens. And lastly, on the front of prevention, we need to scale up PrEP, which means HIV pre-exposure prophylaxis, and other biobehavioral strategies for HIV prevention for vulnerable youth. And when I talk about biobehavioral, that may sound like a buzzword, but really what it means is that we're pairing behavioral change with a proven medication strategy to reduce the risk of STIs and HIV. So we'll break each one of those down one by one. So let's start with ensuring quality comprehensive care. So what does quality mean? So when we talk about quality integrative STI services, what we're really talking about is getting the right care to the right teen at the right time in the right place. And we'll talk a little bit about what does it take to get there, because as you'll see, it's a little bit more complicated than just putting a single clinic in place or adding a nurse. We really need to work across health systems to make these changes. So the first step is really engaging multidisciplinary care teams. So that means not only having our medical providers, such as physicians and nurse practitioners, aware, able, and educated to provide quality STI care, but we also need to partner with our social workers to address some of those essential social service needs I discussed earlier. We need educators. Many of us who are clinicians may not have the time within a very short, busy clinic visit to do all the sexuality education that we need to do. So really partnering with health educators or community health workers as well. And then finally, translators. Certainly in an area like Philadelphia, we have a large limited English proficiency population, and making sure that the information that we get reaches our audience in the right way in ways that they can understand. Within our clinics, we need to think about comprehensive care models. So that means, again, this quality term. And quality means that the care we're delivering is safe, is effective. So we're using strategies, whether they're medications or diagnostic tests or behavioral interventions that have been proven and have good data to back them up. That the care is patient-centered and really focuses, for instance, on teens on the developmental stage of the patient, but also really works to identify an individual patient's needs and goals and meet them where they're at for behavior change. Our care needs to be timely, and it needs to be efficient. We're always going to have the strains of our, brief clinic visits. So what can we do? How can we get care packed into a 20 to 30-minute session in a way that reaches the patient and involves evidence-based strategies? And that it's equitable. So again, getting back to our translation component when we think about our care teams, making sure that all patients have equal access to the same information, testing, treatment, and prevention services. And to do that, we're going to need to reach outside the walls of our clinic to our community hubs and our partners. So thinking out to reaching to our local health departments. So for me, the Philadelphia Department of Public Health are like my BFFs. I talk to them multiple times a day because really we are not going to have the capacity in any sole health system to be able to address this alone. DIS stands for Disease Investigative Services, and wherever you are in the U.S., your health department likely has either an agency or a program that helps do partner tracing and partner notification for STIs. We also need to rely on our mental health service providers because we know that adolescents with STIs have a much higher rate of depression, anxiety, and trauma. Again, social services addressing those basic human needs will be key. And then also reaching out to our schools who not only are our partners in education, but may be our partners in care delivery. So one example is within the Philadelphia public school system, we're able to do annual private screening for chlamydia for all teens. So it's not just getting the education out there, it's being able to meet teens where they're at. If we can't get them in the door of clinic, we need to be able to provide those services within the schools. And really in terms of what is in those quality services, there was a recent document that came out from the Centers for Disease Control and Prevention that goes through what our key elements of quality are, what should be involved in each of these areas to provide quality care and services. And I won't go through each specific area, but just to talk about that quality doesn't mean one thing. It needs to span thinking about delivering quality, starting from the sexual history and physical exam for our patients, going into prevention methods, that partner services piece we just discussed, thinking about evaluating patients for STIs, referring them for a higher level of care if they're beyond what we can provide in the clinic, getting them the right laboratory-based services, as well as the right treatments. And for adolescents, we also need to think about integrated care. So most of the sites where we're going to be delivering sexual health care for teens are not going to be standalone STI sites. And that's actually ideal because what we want to be able to do at our clinical sites is address the multiple needs of adolescents. Again, for teens, this is really a timely issue because most of the time a teenager is not going to be able to navigate going to multiple clinics or multiple providers for multiple health needs. So ideally, under one roof, we want to be able to have our STI care, but also think about contraceptive and family planning services. For our transgender and gender nonconforming youth, thinking about gender affirming care as well. integrating our mental health services, and thinking about family planning. While we make the assumption often in medical care that our teens don't want to get pregnant and we don't want them to get pregnant, in reality, it's important for us to know what those lifelong family planning trajectory goals are for our individual patients, so we can make sure they're not getting pregnant at the time that they don't want to, and that when they're ready to get pregnant, they're as healthy as possible at that stage in life. Again, sexuality health education. If we are not able to get it at the same level as we want in the school, can we get it integrated in the clinics? And then thinking about intimate partner violence. This is, again, a factor that is all too present in our adolescent relationships and can often drive vulnerability for STIs and HIV. So when we think about our ideal care models, we want to be addressing each of these points as well. And the last part of being able to ensure quality services is ensuring our safety nets. So our key safety net in the United States is Title X. And Title X is a federal program that is state administered that provides funding for family planning services. And those are essentially free, usually walk-in services for contraception, education, annual sexual health exams, Pap smears and breast cancer screenings, and testing and treatment for STIs. And in the United States, the Title X program reaches nearly 5 million people annually. However, we know that over the last few years, there's been substantial threats to Title X. So last year, we saw the domestic gag rule emerge, and that was basically a piece of legislation that made it placed restrictions on Title X funding for organizations that performed or referred women to abortion services. The result of this is that many agencies that relied on Title X for funding, but were abortion services providers, such as Planned Parenthood, did need to give up their Title X funding. And it really dramatically reduced the Title X network capacity by almost 50% nationwide. And some states, especially when we look at sometimes our geographically more far-flung states like Hawaii, Maine, and Washington, were more affected than others. In fact, we see that almost 1.6 million women who would have been seeking family planning services may no longer have the same access to services as they did before that piece of legislation. So from a policy perspective, we really need to keep our eyes on what's coming down the pipeline from policy and use evidence to really bring to the forefront the losses of services and the loss of health-sustaining treatments that come with this. Because again, we're not just talking about STI treatment here. This is also potentially loss in contraceptive services, loss in critical cancer screening for women as well. So then let's talk about universal screening. So the case study I'm going to go through here is looking at chlamydia, and I already talked about that chlamydia, is one of the most common of all STIs, and really the most common STI, bacterial STI that we see in young women. And as I mentioned before, what we worry the most about with chlamydia is that in young women, untreated chlamydia can lead to pelvic inflammatory disease, which can have lifelong consequences with respect to fertility, pelvic pain, and risk of pregnancy complications. Universal screening for chlamydia in young sexually active women can almost halve the incidence of pelvic inflammatory disease. By screening, we can detect infection earlier, often when it's asymptomatic, and treat young women quickly before there's a risk of developing PID and other complications. And based on this, the U.S. Preventative Services Task Force, Centers for Disease Control, American Academy of Pediatrics, and American College of Obstetrics and Gynecology all recommend annual screening for sexually active women under 25. However, we know that we're not meeting that benchmark. Adherence with screening guidelines has been poor across health systems, with less than half of women getting annual screening. And in particular, in the pediatric world, we know our screening rates are some of the lowest ones out there. However, I'm going to show you that really simple innovations in care can make a big impact. And so we talked a lot about quality on the policy level. And now when I talk about screening, I'm going to talk about making changes within health systems that can have dramatic impact on screening rates. So this is an example from a quality improvement effort that I helped lead at CHOP in one of our primary care clinics in West Philly. So the metric here that you're looking at is the percent or the proportion of 15 to 19-year-old women in primary care who got an annual chlamydia screening within each of the following calendar years. Now, we're never going to get to 100% in primary care, and that's okay. We really should be screening the adolescents who are at risk, meaning that they're having sex. And so knowing what our sexual activity rates are in Philadelphia, we're probably trying to hit for more of a 50% mark. However, you can see that we were getting close in 2014, 2015, but in 2016, we kind of fell off the map. So what did we do? Well, first we wanted to figure out where the different barriers are in screening. And so we engaged in the process of quality improvement. So quality improvement, we'll talk a bit about in the next few minutes, really involves kind of like rapid cycle change to understand the barriers to a process, address those barriers, and move quickly through them. Now, I had done a little quality improvement before this project. I was quite naive, and I thought chlamydia screening was going to be a really simple process, maybe 4 or 5 steps of what needs to happen from when a teen goes into a clinic to when a teen gets a chlamydia screening, and that there would be a few what we call dependencies, which means points where you could have gone either in the good way or the bad way on the map, depending on a key factor in the process. So our first step was to actually meet with our clinic, with everyone from the front desk staff to the providers, and map out the system and the dependencies. And I love this picture because it kind of shows you how naive I was. Instead of 4 to 5 steps, which are each of our boxes, and 2 to 3 dependencies, we ended up with a process that had close to 20 steps and about 10 different dependencies. But it was crucial that we went through this step because, as you'll hear, involving every member of the healthcare team really allowed us to get a global idea of what was going on at the clinic and what some of the barriers were to screening. One of which was really that providers were often not screening because they were worried about disclosing the confidentiality of the adolescent, disclosing their confidential sexual history to the parent by obtaining a chlamydia test. So what we really needed to do was design a workflow where we could make sure that we were able to get a urine chlamydia screening test on every teen who needed one while keeping their information safe, confidential, and getting effective treatment to them. So what did we end up doing? So we built a multi-step intervention. The first thing we did was really to knowledge surveys with the providers to make sure that they understood, first, the importance of screening for chlamydia, so they had some buy-in in the process, but also that they understood our local state confidentiality law so that they knew what information they could disclose to parents, what information needed to stay private with the teen. We then did a multidisciplinary staff training on the intervention we developed. And really, I'll just kind of cut to the point and say our key step was making sure that we could get a urine specimen on every single teenager before they walked into the exam room with the provider. And by getting a urine specimen on everyone, we then didn't have the situation where we were kind of juggling teenagers in and out of the room and into the bathroom once we found out that they were possibly having sex. We put signs up around clinic to kind of destigmatize the process. So again, taking the mystery for the parent as to why your teenager is going into the bathroom, there was a sign in every room that said all teenage patients will have a urine specimen obtained for screening for infection at their well visit. Fantastic. So that gets away from that stigma barrier, and that gets us to more of a universal process. And then again, we were able to get the urine on every single teenager at the same time that they got their vital signs. And we built an order set into our electronic health record to streamline ordering. Now, this last part was probably the most labor-intensive and expensive part, but I also think it was probably the least effective. So if you're sitting here watching this and you're in a more low-resourced area where, for instance, building electronic order sets aren't going to happen, I would say that the most bang we got from our buck was really in redesigning our workflow, which involved no technology and just involved engaging our staff and really building buy-in within the intervention. From there, we went into the process of a PDSA cycle. So if you're familiar with quality improvement, you've seen this before, but if not, I'll just break it down. PDSA stands for Plan, Do, Study, and Act. And a little different from research, where we come up with a question, we spend a year studying it, we get a finding, usually 6 months after we're done with the study. We maybe move into action at that point. Quality improvement is fast, fast, fast. So you make a plan. So in our case, we determined what our barriers were to screening. You build a solution to the plan and you do it. It may not be perfect, but you're going to evaluate the efficacy of what you're doing based on just studying your data, reviewing what you're getting, reviewing your screening rates, and then acting on that. So if you do something and it doesn't work, you make a change. So how did we do? Within a year, we were able to get our screening rate for the first time ever to that 50% mark in clinic. So that was about a 10% increase from our baseline rate, but that's an absolute increase. What we really care about in quality improvement is a relative increase. So by how much of the baseline percent did we increase? And that was 22%. And what we consider that for interventions is that that is a pretty big effect size. So we were thrilled that we were able to do this. Now, were we able to sustain it over time? It's been a challenge, but we've gotten there, and it's required a lot of ingenuity and a lot of fun. So one of the ways we've sustained is every Valentine's Day, every nurse and doctor gets a candygram with a little chocolate heart and a little pink sheet that says, "Hey, everybody, it's Valentine's Day. Remember to screen for chlamydia." So doing these little boosters over the years has helped us sustain the success of this intervention. So let's look at a couple of other possibilities for how you can make small changes in practices to get big gains. A really low-tech example is just going to universal opt-out screening language. So that means that instead of deciding to screen certain teens and not others, or having to make decisions based on sexual activity, just at the beginning of the visit using the language, we screen all of our patients, all of our teen patients for sexually transmitted infections, in keeping with recommended pediatric guidelines, and because our rates in Philly are some of the highest in the country. This particular practice has been extremely effective in our clinics that have a very high rate of private insurance. Again, those privately insured teens, if they get a chlamydia screen, there's very likely going to be an explanation of benefits that goes to the house that can be sort of a threat to their confidentiality. However, if you can let the family, meaning the teen and their caregiver in advance, know that screening is standard, give them the possibility of opt-out, but make it the norm to do the testing, you can really improve screening rates. And I'll show you some data on that in a second. We also put this information in signage. We put it in posters. And we've been working on creating a welcome letter that goes throughout all of our clinic practices. We have over 31 clinics in our network, so that it's standardly known across the network that this is what our institution recommends, this is what our guidelines recommend, and this is really best practice for teens. And I will tell you, what I've heard from providers is that we have many grateful families. They want the screening, they want the assessment, but they may not be comfortable having that conversation with the teenager themselves. And sometimes, a recommendation may just not be enough. So we had another practice that wanted to engage another strategy, which was doing a little bit of what we call social competition. So think about being on the leaderboard in Dancing with the Stars, right? One way we can do this is showing how providers are not just doing themselves, but seeing what their screening rate is compared to, for instance, if you're an attending physician, the other attending physicians in the practice, or what the clinic looks like overall, or the CHOP network. Everyone gets their own individual report card, so no one's getting publicly shamed by this. But I will tell you, most healthcare providers do not like being at the bottom of the barrel. So this can be a huge motivator for people to change as they sort of rise to meet the higher screening group rate that we're trying to achieve throughout our network. And I'll show you how well these work. So this is a clinic that did that universal screening policy alone. This is a suburban clinic that's primarily privately insured, and they started around this past summer, July 2019, to just tell all parents that their goal was to screen all teenagers. And they've been able to get up to a nearly 70% screening rate, and they've had consistent gains and improvements. Now, what about if you did the universal screening plus the social pressure? Well, here we got huge success. So we started around the same time, July 2019. And I'll tell you a funny thing here is that if you look at this, you probably would think that that first report card went out right with that steep line around mid-July. It actually didn't go out until September or October. It was just telling people that we were going to do the report cards that was able to make that really fast, substantial change. So that was an example of chlamydia testing, which is one of the areas that we're working hard to improve screening. But another area that we're going to be focusing on improving when we're thinking about screening recommendations is improving HIV testing. So here I have the CDC guidelines listed for HIV testing in populations. And what we see, whether you're male or female, is that everyone 13 to 64, whether they're having sex, whether they're coming in for a sexual health concern, should be getting screened for HIV. And that should also be what we call an opt-out screen. That's the same as our universal chlamydia screening language, saying the recommendation is to be screened, and then people have the opportunity to not screen, but you're really normalizing that screening practice. But in addition, we want to be screening everyone who's coming in for any sort of evaluation or treatment for a sexually transmitted infection. And that's an area where we have a lot of room to grow. So why do we need to work so hard to improve HIV screening in the United States? Well, here this is something called the HIV continuum of care. And across the y-axis, so the vertical part of the chart, you can see the percent of people living with HIV in the United States. And then moving across the x-axis, or the horizontal part, we see the different stages of HIV care. So if you're HIV positive, have you actually had a test and been diagnosed to find out you're living with HIV? That's our first step. After diagnosis, have you been linked to care? That means, have you gone in and actually had a clinic visit for your HIV infection? After that, have you been retained in care? Are you going into clinic at least twice a year, which is our current standard, to be able to attend to your health needs with respect to HIV? And our last step is viral suppression, meaning, do you have an undetectable viral load on medications to treat HIV? And that viral suppression piece is important for a couple of reasons. One, it means that when someone's viral load is suppressed, they're no longer at risk for their HIV infection progressing. But number two, and very importantly, we know that when people are undetectable, they're untransmittable. And this is amazing. This is something that came out of really excellent clinical trials research over the last few years. Is that we know that if someone has an undetectable viral load, their risk of transmitting HIV is zero. So again, I'm going to go back to this care continuum slide and say that probably our most important parts here are, number one, diagnosis, because we know that if you're not aware that you have HIV, you're not able to get into care, get on medication, and suppress your viral load. And then number two, once you're in care, reaching that metric of viral suppression. The other thing I want to emphasize about this graph is the brown bars are kind of the whole total U.S. population living with HIV. And you can see that if we looked at every single person who's living with HIV in the United States, we only have about 50% of that population who are virally suppressed. If we think about our global health goals, it's to have 90% of people diagnosed, 90% of those linked to care, and 90% of those virally suppressed. So we have a ways to go. But again, on that message that our teen and young adult populations tend to be more vulnerable, we can see that those metrics are much lower in youth. So when we think about scaling up interventions and we think about scaling up universal screening, HIV screening for youth is a really critical area to focus. Now, one of the things we've looked at CHOP is, in addition to universal screening, are we able to recognize and identify those youth who are most vulnerable? So those are the young people who are coming in for diagnosis and treatment of a sexually transmitted infection. So we did a study that just was published in the journal Pediatrics this last week that looked at 1,816 adolescents who were coming in with a new positive STI in our network. And we wanted to see how many of those were getting an HIV test. It should be 100% based on those CDC guidelines that we looked at. And what we found, and you can see this on the pie graph, is only about 55% of those teens were tested. So only 55% got an HIV test within 3 months of a new sexually transmitted infection. But when we look at that 45% who did not get tested, we could see about a quarter of them actually had a test ordered, but they didn't make it to the lab to get the blood test done. And I really emphasize this because this is another message that we'll talk about today, which is meeting teenagers where they're at. So our traditional model of going into clinic, you get an HIV test ordered, you're sent down the hall to the lab to get your blood drawn. We know we're going to miss many teenagers in that getting down the hall step. So again, when we think about quality, we need to think in our health systems not about just doing interventions to improve screening, but to actually meet youth where they're at to get the test to them just a little bit more easily. So there's been an interesting piece of policy that's come down the pipeline in the last year, and that's the Ending the HIV Epidemic platform. And so we often refer to this as ETHE, and it's really a plan to dramatically reduce the new HIV infections in the U.S. over the next 10 years, so shooting for a 90% reduction. So what are the different steps here? So we've talked about some of these already. The first step is diagnosis, so trying to get people screened and increasing HIV testing so we can recognize HIV as early as possible. We want to get rapid treatment to get that suppressed viral load. Our third platform is prevention and protection, so using some of our biobehavioral strategies like PrEP to reduce new infection rates. We want to respond to new clusters of HIV infection, and we want to expand our HIV health force. So that even means thinking about us in primary care pediatrics being able to deliver, if not HIV care, at least high-quality HIV prevention. So let's move over into that field and talk a little bit about scaling up evidence-based prevention. So the biggest game changer in the pipeline for HIV prevention has been PrEP, or HIV pre-exposure prophylaxis. And right now, PrEP refers to taking daily oral antiretroviral medication. This means medication that we've used for many years to treat HIV, but we use it now as a daily med to prevent HIV, and it can reduce the incidence, so it can reduce new HIV infections by up to 90% if taken regularly. Because of this, PrEP is now recommended as part of comprehensive HIV prevention services by many public health guideline agencies. And just in the last year, it actually got a grade A recommendation from the U.S. Preventative Services Task Force to be part of standard preventative primary care for people who are highly vulnerable to HIV infection. And what's exciting about PrEP is that daily oral pills are PrEP for about the next 15 minutes. We have a lot of exciting tools coming down the pipeline, such as the potential for vaginal rings, rectal microbicides or vaginal microbicide agents, or injectable medications, all of which can be used as PrEP. When we think about who should use PrEP, we're largely using criteria that have been set forth by the Centers for Disease Control and Prevention. And when we use these criteria, about a quarter of men who have sex with men, and that's men and trans women who have sex with men, and a little less than 1% of heterosexual adults meet the U.S. criteria for PrEP. And as I go through these criteria, I just want you as the listeners to think about how these apply for young people, because I think they're challenging to apply them to our adolescent population. So for anyone who's at sexual risk, we want to think about PrEP for anyone who's had sex in the last 6 months and isn't in a monogamous relationship with an recently HIV tested partner who's negative. And if it's a man or trans woman who's having sex with men, is having condomless anal sex in the last 6 months, or has had any bacterial STI, or if they're heterosexual, they're not using condoms frequently, with partners who they don't know their HIV status, or partners who may be at substantial risk of HIV, or who have had gonorrhea or syphilis in the last 6 months. Again, important to screen for STIs because that can allow us to know about vulnerability to HIV as well. And on the far right are our criteria for injection drug users, which basically involve using any injectable drug and sharing equipment or works in the last 6 months. Now, when we think about this, so many of these criteria really rely on knowing what people's partners are doing. And I would argue that that is very challenging to do. I think potentially even for older adults. But for many of my teens, they don't know if their partner has other partners. They don't know when their partner was last HIV tested, and they don't know their partner's HIV risk. So in addition to these criteria, I would also urge people who are taking care of adolescents to think about PrEP for anyone who asks for it, or that you perceive to be highly vulnerable to HIV for other reasons. So for instance, if someone has had multiple chlamydia infections, or if someone is engaging in transactional sex, or if someone's had multiple partners in the last year, even if they don't meet these exact criteria. Because I think those CDC guidelines may work well for older adults, but they are not a perfect fit for our adolescents. Now, one great piece of news that came around the corner in 2018 was the approval of Truvada, or tenofovir emtricitabine, as PrEP for adolescents at risk for HIV. So this is fantastic news because we're no longer having to use an off-label medication for HIV prevention. And just in this last year, we've had a new medication approved for PrEP. So in addition to tenofovir emtricitabine, known as Truvada, we have tenofovir alafenamide plus emtricitabine, which is Descovy. And there's some small differences between the two. Truvada requires a slightly higher tissue concentration, has the risk for more toxicities at a kidney and bone level, but it can be used in teens. It has approval, and it has the ability to be used with all sexes and all genders. Descovy is a prodrug, and what that means is it bypasses some of that that kidney metabolism, meaning that it can generally be safer for the kidneys and bones. You need smaller doses, but it can cause increased weight gain and cholesterol. But it's not for use from those at risk for vaginal sex. And I threw this slide into a webinar that focuses on policy because when Descovy came out, I think we're going to have a number of policy type issues to juggle. Are we going to get the same payment and coverage for Descovy as we are for Truvada? I've also seen that there's sort of some norms that are evolving in communities of PrEP users where there's a sense that Descovy is like the better or more designer version of PrEP, when in fact we have many, many good years of use with Truvada. We have good safety data, and we have good cost efficacy data. And I would still argue that unless someone has toxicity risk for kidney or bone, that we should still be going with our standard and proven treatments. Now, when we think about PrEP, I always like to think about the final question of who are we missing? So when we think about who is at risk, we think that there's probably about 1.2 million people at high risk for HIV who could benefit from PrEP, and we're missing the boat on many of them, youth being one of those key populations. So we have to think a little bit more about how we get creative, how we can meet youth where they're at, and how we can effectively scale up PrEP for this population. That's going to involve work on many fronts, including insurance regulations that make it easier for young people who are on their parents' private insurance to get PrEP without a possible privacy disclosure. So when we think about that HIV care continuum that we talked about, we also have a PrEP care continuum because getting our patients on a biobehavioral prevention method is a many-stepped process, as you can see, that spans from awareness to uptake and then finally effectiveness, meaning that people are on their PrEP, adhering to it, and are retained in care. But the most challenging piece of the puzzle for youth is going to be able to get people in the door to access PrEP, get them linked to the right person who can prescribe, getting that prescription in hand, getting that prescription filled. I've had a number of teens tell me that filling their PrEP was the first time they had ever gone to a pharmacy and they didn't actually know how to do it, and actually getting the bottle in hand and the ability to initiate PrEP. So we have a number of innovations that are coming through to improve PrEP access. One is a new program called Ready, Set, PrEP that's coming out of DHHS, and that'll be unveiled in the next year. And the goal of this program is really to improve the ability to get no-cost PrEP to low-income people. We also want to think about telehealth strategies for PrEP. So as we're expanding telehealth for many things during the COVID epidemic right now, I think many of us are stretching our muscles a little bit to get into the telehealth area as well, so that we're able to reach patients who are maybe in more rural areas, who may, because they're adolescents and may not have their own means of transportation, have decreased access to actually getting in a clinic door. And then there's a lot of really interesting programs that are going on in states that allow for pharmacist prescription in terms of doing pharmacist-delivered PrEP, where a pharmacist, usually with a physician backup, is able to do that initial visit, and so that people can walk into their community Walgreens and start PrEP instead of having to wait to identify a clinic, make sure their insurance is par, and schedule. So these are all great ways to kind of streamline that flow. And then I keep talking about meeting youth where they are, and I'm excited to say that at CHOP, we've really expanded our ability to do that in the last year. So we're in the process of developing a mobile health clinic that's going to be able to deliver education, STI, and HIV screening services to youth where they live. And that means that many of our young people that may have transportation or insurance barriers, we can come to them instead of trying to navigate the many different ways to get them to us. And that's my wonderful team on this slide. And then the last piece we need to think about in prevention is evidence-based STI prevention in the form of expedited partner therapy. So EPT is the practice of treating partners of STI-positive patients without having a face-to-face visit. So that means if I diagnose someone with chlamydia, I can either give them a paper prescription or pills to give to any partners in the last 60 days. This isn't recommended for men who have sex with men or young trans women because of high rates of HIV in those populations. We want to see them face-to-face to get the HIV screening done as well. But for heterosexual teens, this can be a really dramatically effective strategy to improve partner notification and partner treatment, and thereby reduce population STI rates, and is recommended by the CDC. However, we see in pediatric practice a lot of barriers to scaling up EPT. So Cynthia Mullen, who's an emergency medicine physician and a critical part of our policy lab team, did a study that looked at pediatric ER physicians, and only 20% of them were reporting offering EPT to 13 to 17-year-olds. Now, you can sort of say, oh, well, maybe they're worried about risk or toxicities or allergies in those partners. However, in that same group, 80% had either sometimes or always offered antibiotics, which again, it's usually the same antibiotic that we would use to treat an STI, to household exposures, household members for pertussis or whooping cough exposure. So, there is a barrier here that's not just about antibiotic risk and safety, but is really a perceptual barrier about teens and sexuality and education that we need to get past. And even when we get beyond that, we have a number of legal barriers to EPT. So in orange, we can see the states where EPT is potentially allowable. In red, states where it's explicitly prohibited. And in green, where it's permissible. And I, in Pennsylvania, am in one of those permissible states. But permissible really places us in a legal gray area where it's not explicitly allowed. And when it's not explicitly allowed, clinicians are not immune to any prosecution and are not given a mandate to provide EPT. So if we want EPT to work, we really need to work on a legislative level to be able to make those changes. Fortunately, PA is a state in which we may have some upcoming bipartisan legislation to make EPT explicitly allowable in PA. So keep your fingers crossed and your ears open. And then lastly, our last sort of preventative point that I want to focus on is vaccination. So vaccination for human papillomavirus, hepatitis A, hepatitis B are all methods of STI prevention. And again, with each of these, we need to think about how we can innovate to get this to adolescents. So many states do not allow adolescents to self-consent for vaccines. However, allowing adolescents to consent for vaccines in the same way that they consent for other sexual health services such as contraception or STI screening may go a long way to improving adolescent adolescent vaccine rates for HPV. Interestingly, in Philadelphia, we actually have some guidance from our local public health department that allows adolescents within the city to consent for vaccines. However, because that is unclear how that can conflict with state policy, it's a mandate that doesn't often get carried out. We also can see that quality improvement intervention, similar to what I talked about for chlamydia, can have dramatic effects in QI in rates of HPV vaccination as well. And then other states have explored thinking about HPV as a mandatory required school vaccine as well. Now, I'm going to wrap a little bit with some key takeaways, but before that, again, we kind of want to talk a little bit about what's happening in the world right now with COVID-19 and how that's going to affect our landscape with STIs. So, right now we're in a large state of unknown. Almost all of us who are primarily providing sexual health services have moved away from a clinic model because we want to reduce the exposures to our patients to coming in the door of clinic. Because of that, there's dramatic decreases in STI testing. When we're not testing, we're not identifying infections, we're not treating, and then we're leaving people not just with their own health consequences of having an untreated STI, but we're leaving them in a state for a longer period of time where they can potentially have forward STI transmission. Now, on the flip side, we may find that social isolation means decreased sex across the population, but that may not bear out. We've seen a lot of sort of media hype about how particularly adolescents and young adults may feel sort of immune from the risks of COVID and may not be taking the social isolation precautions. We also see that we're going to see a lot of diversion of public health program services and funding from STI and HIV services to COVID-19 response, and that's appropriate right now, but we do need to think of what's going to be left over at the end of the day when we kind of move back into our normal operations. In addition, we're doing a lot of empiric treatment of antibiotics, empiric treatment of STIs with oral antibiotics. So a month ago, I would have never imagined using oral antibiotics to treat gonorrhea, which is GC here. But now it's my standard because I feel like the risk to my patient of coming in the door of the clinic and acquiring COVID is greater than any potential risk of antibiotic resistance from doing that empiric treatment. But we'll have to see if we're seeing increases in antibiotic-resistant gonorrhea at the end of the day. And then finally, we've been talking a lot about supply chain for personal protective equipment, or PPE, but we do also need to think about our supply chain for safer sex, thinking about condoms and lube, both from a manufacturing perspective, because we know that many businesses are at risk, that many businesses are at risk because employees can't come in and work in the manufacturing sector, and that supply chain and distribution is down. I did a quick GoPuff search last night to see how this is affecting Philadelphia, and I will tell you, while we can still get condoms in our area, there's essentially no lube that was available in Philadelphia when I looked last night in preparation for this webinar. So I think, that's a best case scenario in a large city too. So when we think about rural areas where you don't have a delivery service that can drop off services in 2 hours, stores are closed, you can't pop into the corner store, how are people getting what they need for safer sex supplies? Philly, I always have a lot of civic pride. We're having a great public health response to COVID, and so one way is by providing home HIV testing when clinics are closed. So people can go to phillykeeponloving.com and order home HIV tests. We're keeping our essential services going through our flagship STI Health Center, which is our Health Center 1 in Philly. Most patients are being seen through phone triage, but if people do need to come in, they have an option. And again, we're scaling up our use of empiric antibiotic therapy to keep patients at home whenever possible. We're also trying to work a little bit on this condom supply. I'll show you a little graphic for that in a minute. And then scaling up telehealth and e-health dramatically for things like PrEP refills and contraception. So, for people who do need their condoms at home, they can always go to the Philadelphia Department of Public Health Do You Philly website and order them online, bypassing the need to go to the store or have your GoPuff delivery person come by. And in addition, on a national level, we're seeing that there is a command center that's coming up through the National Coalition of STD Directors to provide expert guidance, support, and services for those who are sort of on the front line with STIs. So I'm going to wrap up now and just go over a few key takeaway points. Number one, we need to keep our funding intact for our safety net services. We talked about Title X. Ryan White is our HIV safety net. Organizations like the CDC, who are really taking a beating right now with COVID, as well as the critical work done by our local public health departments. Secondly, we need to have a strong emphasis on comprehensive and quality services that are developmentally tailored towards adolescents. Number three, we need to work within our large health systems to create system-based change to improve universal screening for STIs. Number four, we need to think of those innovative solutions to reach youth. The one sort of silver lining, I'll say, of the COVID epidemic is that in 10 days, we were able to do for telehealth what would have taken us 10 years otherwise. Number five, we need to advocate on a legislative policy level to open up access to EPT and make sure that we're setting down safeguards to EPT practices across state and local jurisdictions. And above all, we all need to, particularly in these difficult times, hold on to our dedication, our passion, and creativity to face our public health challenges head on and improve health outcomes to vulnerable teens and adolescents. I want to acknowledge all of our safety net programs, LEA and the National Institute of Mental Health for support, all of our hardworking CHOP primary care practices for their quality improvement efforts, the many excellent agencies who provided infographics, and all of my patients and all of our patients who make us better and more human in what we do. If you have any questions or comments, my email is here, and you can feel free to reach out to me. And I hope you all enjoy the rest of your day. Thank you very much.